Okay, so are you saying instead of the drug companies have been obsessed with targets,
Right.
finding targets, first in class, best in class. So you're saying instead of finding new targets, you can look at the existing treatments and combine them to achieve the effect that you want.
Well, I think it's a hybrid, if you will. I think
Okay.
we have already in our armamentarium some very good targeted agents.
Mm-hmm.
And I think so we can, together with our patients, learn how to use those agents better.
Mm-hmm.
As it turns out, we also have the ability now in our science to determine what would be a novel target
Yeah.
that, if inhibited, would enhance the activity, for example, of bortezomib or lenalidomide or other agents.
Mm-hmm.
So we can use science to inform the design of combinations. If we have already the right combinations, terrific. If not, the science at this meeting and elsewhere is defining targets that are required by cancer cells to grow and survive, and therefore stimulating a lot of research and clinical drug development to hit those very vital, important targets. The other thing I want to mention quickly here
Yes.
is that targeted therapy combinations can occur in one of two ways in a
I was going to
practical.
ask, how do you find that combination?
Right. So, well, we can find the combination based on our science. The drugs would be targeted and added together because they enhance killing, avoid drug resistance, or as I mentioned earlier, they're more user-friendly, so patients have fewer side effects.
Mm-hmm.
The issue is that often those targeted therapies, having been identified, are from different companies.
Right. So that could be an issue.
Well, the model historically, right, has
Yeah.
been free enterprise and competition.
Right.
But people like myself and others who study the biology of the different cancers have the unique opportunity to say to different companies,
Mhm.
your agent combined with your competitor's
Yeah.
agent on a
Mhm.
business level are synergistic, and it's best for patients if you combine the drugs.
Right, right.
And the example I mentioned earlier of bortezomib and lenalidomide is exactly that. Those are different companies that are competing,
Right.
but when they came together, we have an unprecedented treatment for our patients. So that's extraordinary, and it's an example of how we need to keep our focus on improving the lives of our patients above all.
Right. You are closest to the patients. I mean, you're in between the patients and the drug
Mhm.
companies trying to develop the treatment, the drugs, but you really are closest to the patients, so
Right.
you have that perspective.
We absolutely do, and I think pretty much no one company is big enough, even the largest pharmaceuticals, to have all the appropriate members of the team
Right.
in their own company. So it is going to be necessary to partner, number one. The other thing that's happened at this meeting and is illustrated here is that combination therapies can be designed so that there have been talks here where companies have looked and done research to suggest that you should inhibit 1, 2, or 3 different circuits. And instead of using individual agents that target each of those 3 circuits, for example, they've designed drugs, designer drugs. They're targeted therapies, but they simply have 2 or 3 targets in one medicine. So you can either use more selective single-targeted treatments together in at least 3, 4, or maybe even more members of the team, or another trend is to say, we know that these 3 targets are important, so let's see if we can't design one targeted medicine or treatment that can hit all 3 targets at once.
Right. That sounds really nice.
Mm-hmm.
Have you seen it actually occurring in reality, or is it just a thought that people are bouncing around? And how, in reality, will the companies, these for-profit companies, and as you say, they are competitors, actually do this on commercial terms?
Well, I think it is difficult. I nonetheless think it is achievable. We have in our multiple myeloma context achieved this with the drugs lenalidomide, bortezomib, and dexamethasone really becoming a standard when put together now and achieving benefit in every patient treated for newly diagnosed myeloma. So the example is set.
Okay.
And on a business level, it will be very positive as well. All patients will have access, all patients will respond, and even in the new world, if we measure our outcome in medicine and that becomes the basis for reimbursement, if you have treatments which are very, very effective, they will be very reimbursed as a consequence. So I think the pressures are going to be there.
Right.
Not only from a medical sense on behalf of our patients, but
also from the healthcare system.
Absolutely, also from the healthcare system in the future.
Right. Well, that's very exciting. I'm very glad to have talked with you about this.
Well, it's my pleasure, and that's every reason to be very optimistic. I believe the next several years in cancer are going to be unprecedented.
Really?
Because I really do, because the science is ready to explode, and if we can work together, which is reflected at this meeting, the academics, the pharmaceuticals and small biotech companies, the regulatory agencies, the funding agencies, and most important, the patients and advocacy groups. If those 5 constituencies work together, we will be able to make science count for patients, translate these advances from the bench to the bedside for the betterment of all.
Right, right. I was going to say, although Western medicine has made great strides in the fight against cancer, there have been tremendous limitations, drug resistance and the relapse and, even some blockbuster drugs, they have really just marginal improvement. So I guess it is rather a hopeful message coming from you that perhaps this is a direction that could bring out some tangible, really significant improvements.
I think it is a very positive message, but it's a very realistic message. I don't want to overstate things, but we have simply now an understanding of the science at a genetic level that's been unprecedented, so we can hopefully in the near future figure out which treatment should be given to which patient at which time, such that their outcome will be favorable and therefore it will be reimbursable. We won't be using ineffective therapies any longer. And I think that there's every reason, and this history of the last several years suggests this to be the case, that with that team that I mentioned to you, reflected here at this meeting, pharmaceuticals and biotechs working along with academics, working with regulators, working with funding agencies, and most importantly, remembering putting the patient first, it's guaranteed that this success will result.
Well, upon that great note, thank you so much for talking with me.
It's my pleasure, and I commend you for helping caregivers and patients alike.
Oh, not nearly as much as what you do for the patients.
Together we will win.
Okay, great. Thank you for watching. That was Dr. Ken Anderson from Dana-Farber Cancer Institute. Look forward to having you back for more great conversations on Acinova.